Hello, these are the podcasts of pain. This is part 2, assessment of pain, and also we'll be looking at tissues and pain. So assessment of pain. Different people have different pain tolerances and different ways of coping with it. Pain as an experience is subjective. Pain can be scored objectively via the use of a visual or verbal analogue scale, a VAS, but such measures must still be recognised as subjective perception. Pain questionnaires are well established in pain clinics and back care environments. The McGill Pain Questionnaire, described in Melzack 1975, incorporates sensory, affective, evaluative and miscellaneous components. It considers pain patterns, intensity and a pain diagram. The Oswestry Low Back Pain Questionnaire, cited in Fairbank et al. 1980, measures the patient's perception of their functional disability. The Victorian Institute of Sports Assessment Scale, the VISA scale, is a reliable questionnaire for assessing the severity and progress of tendinopathy. Other signs of pain include guarding, where the patient assumes stiff postures and rigid movement patterns, rubbing, where the patient frequently massaging or holding affected painful areas, grimacing, facial expressions of pain, sighing, exaggerated air exhalation. Psychogenic pain may be considered as that which is generated or exacerbated by the mind and emotion of the patient. Obviously, patient's attitude, mood and previous experience influences their pain perception and experience. However, the sports therapist should attempt to recognise when the patient may have a distorted or irrational perception, as there will be occasions where patients present with inappropriate subjective or objective assessment responses. Clues to changes in an athlete's pain may also be observed as their levels of function or performance improve or worsen, and also by the amount of analgesic or other medication that they take. From an assessment perspective, sports therapists must recognise that pain has a severity, an irritability and a nature, as in sin. Tissues and pain. Pain consists of a wide range of sensations, ranging from sharp, brief, cutting pain, such as that perceived when treading on a pin, to long, prolonged, intense, dull pain, such as that experienced by bone cancer patients or individuals recovering from a muscle rupture. Bone pain typically is felt as deep pain. An acute fracture will produce excruciating pain and make mechanical loading unbearable. It's important to recognise that neoplastic or cancerous lesions of bone, where primary or secondary commonly produce a deep aching pain, which is unaffected by movement. If there's an infection involving bone, such as with osteomyelitis, there can be local heat, swelling and palpable tenderness. Muscle pain will vary with its cause and severity, for example cramp, strain or hematoma. If a muscle is injured, it's likely to be painful to actively contract, resist load or stretch. Acute tendon pain, i.e. as in a reactive tendinopathy or tenosynovitis, is typically sharp in character. The pain of degenerative tendinopathy or tendinosis has been described as a grumbling chronic discomfort. In tendinopathy, the pain may be more pronounced at the end range of movement when the tissue is on stretch. During a range of movement, when resistance is involved, or when the tendon is being compressed or impinged against other structures during a range of movement. Acutely injured ligaments typically present with a sharp pain, which is easily exacerbated when in a position of stretch or stress. However, a complete rupture will sometimes be reported as pain-free, and post-acute sprains may develop a dull or aching. Neuropathic pain often has a particular pattern associated with it, which relates to central radicular dermatomal or myotomal patterns or peripheral sensory distributions. There is also likely to be associated motor or sensory loss. Peripheral neuropathic pain may be due to mechanical injury, such as intervertebral disc herniation or brachial plexus injury, systemic autoimmune or degenerative pathology, infection or neoplasia. Symptoms may be bilateral or unilateral, and there may be autonomic involvement. Neuropathic pain resulting from peripheral neural tension typically presents when the nerve pathway in question is sufficiently tensioned during functional movements or testing positions, as in neural tension tests. It's likely to be initially sharp and shooting, but can become deep and aching. The term causalgia is applied when a syndrome combining sustained burning pain, allodynia, which is pain due to a stimulus that does not normally provoke pain, and hyperpathia, an abnormally painful reaction to a stimulus, occurs, usually following traumatic nerve lesion. Such a condition may lead to trophic changes. This is due to interruption of nerve supply, such as vasomotor, angiokinetic innervation of arterial walls, or pseudomotor, nerve supply to the sudoriferous or sweat glands, dysfunction. Pain with a vascular component, as in a deep wound or in an acute inflammatory response, can produce a throbbing type pain. Visceral pain is that of organ origin, which generally means its source will be within the thoracic, abdominal or pelvic cavity. Whether acute or chronic, it can present as local or referred pain, or both. Visceral pain referral patterns have been documented by numerous authors. Referred visceral pain is quite typically diffuse and difficult to localize. It may present superficially in cutaneous tissue, and there may be hyperalgesia. Pain can refer to tissues sharing the same nerve supply, and referred pain usually emanates away from the center towards the periphery, is poorly localized, exhibits less tenderness than expected, and is likely to fail to respond to local treatment. As a broad generalization, thoracic organs will refer pain to the upper thoracic spine and upper extremity. Abdominal organs will refer pain to the middle back, and pelvic organs refer pain to the lumbar region. It's imperative that the sports therapist recognizes the possibility of referred pain when assessing patients. Amputations bring additional and specific categories of pain. Phantom limb pain is the continued perception of pain from the amputated limb. Essentially neuropathic, this type of pain is typically described as burning, shooting or cramp-like. Stump pain is from the remaining tissues at the site of amputation. The patient may have continued irritation from a prosthesis, or the pain may relate to local neuroma, ischemia or infection. Here endeth part 2